Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
The guest on this podcast episode has no disclosures to declare.
Welcome to this JCO Article Insights episode for the December issues of the Journal of Clinical Oncology. This is Davide Soldato, and today I will have the pleasure of interviewing Dr. Knikman and Dr. Cats, respectively first and corresponding authors of the manuscript titled Survival of Patients with Cancer with the DPD variant Alleles and Dose-Individualized Fluoropyrimidine Therapy, a matched pair analysis. Dr. Knikman is a clinical pharmacologist and assistant professor at the UMC Utrecht, while Dr. Cats worked as a gastroenterologist specialized in and working in gastrointestinal oncology at the NKI in the Netherlands. Welcome, Dr. Knikman and Dr. Cats, and thank you for accepting our invitation today.
Thank you so much for the invitation.
So I just wanted to start a little bit discussing the manuscript that you published, but before delving into the results of the manuscript that was published in the JCO, I just wanted to ask you if you could give a little bit of a brief overview of the DPD polymorphism and explain a little bit the relevance in clinical practice.
DPD polymorphism is very important in the metabolism of fluoropyrimidines. So fluoropyrimidines have been in practice for over 7 decades now in the world, and more than 2 million people received fluoropyrimidines in the beginning of this millennium, and the indications for fluoropyrimidines have since then only been extended. So a lot of people are receiving fluoropyrimidines. But with the good side of that, there's also another side, and that is that there are a lot of side effects encountered by this chemotherapeutic drug. And in the 1990s, it became clear that DPD was a key enzyme in the metabolism of fluoropyrimidines.
So to better understand the toxicity which fluoropyrimidines are accompanied by, you have to take a closer look at the metabolism of fluoropyrimidines, and more specifically at the key metabolic enzyme, which is dihydropyrimidine dehydrogenase, DPD in short. And this enzyme breaks down the main active metabolite into inactive metabolites, because 5-fluorouracil is the main active metabolite, which is metabolized into inactive metabolites. However, if this enzyme doesn't function properly, this could lead to higher exposures of the active metabolites and subsequently lead to more toxicity. This can be caused by mutations in the gene encoding for the DPD enzyme, which is the DPYD gene, and single nucleotide polymorphism. So mutations in this gene can lead to less functional DPYD enzymes and subsequently can lead to more toxicity.
So basically, patients that are harboring these SNPs in the gene encoding for the enzyme, they have a higher risk of toxicities. And I think that what is really important about the manuscript that you publish is that apart from looking at the toxicity side effects and so the profile among these patients who harbor these SNPs, you also wanted to check whether this was associated with some reduction or at least with inferior clinical outcomes. And the endpoints you selected were progression-free survival and overall survival. But I was really interested, and I think that also our readers and listeners would be interested in understanding a little bit the methods of the study. So what was the cohort of patients that was selected? Was this a cohort composed only of patients with gastrointestinal malignancy or also different type of malignancies? And in this second case, so if you included patients with different type of malignancies, did you have any type of methods to be sure that there was not any differences among these patients at the very beginning? So basically, how you handled all the confounding factors that could potentially impact on the analysis on clinical outcomes?
Perhaps to start your question, we have to go back to a previous study we performed, which was a prospective multicenter study we performed in the Netherlands in 17 centers, in which 1,100 patients that had an indication for fluoropyrimidine therapy were included. And in these 1,100 patients, there were about 85 patients that were heterozygous carrier of a DPYD variant. And what we did that we compared these two groups with each other, but before the DPYD carriers started, they had a reduced dose. The STAR 2A variant carriers and the STAR 13 carriers, they received a 50% dose, and the 1236 and the 2846, they received a 75% dose. Those patients, a large amount of them consisted of patients with colorectal cancer, about 60%, and also breast cancer patients consisted for a large amount of this group, which was about 20%. And then the rest were esophageal and gastric cancer mostly. And it was a group consisting of rare tumors as well, like anal cancer. The comparisons showed that toxicity in the variant carriers was higher in the wild type patients that received 100% dose. So despite dose reductions, toxicity was higher in the carriers. But when we compared the variant carriers with historical controls, we saw that especially for the STAR 2A, there was a large reduction of toxicity to a lesser amount. This was also the case for the 2846 variant carriers, but to a much lesser extent, there was a reduction in the 1236 carriers, which worried us. And this was the basis for a clinical pharmacogenetic implementation consortium to give a recommendation for starting for all these variant carriers with a 50% dose when treatment with fluoropyrimidine was indicated.
Thank you very much for the clarification. So basically, you started from one previous prospective study that was composed of a mix of different cancer types. And then in this study that now you published in the Journal of Clinical Oncology, you also added an additional part of patients who were carrier of these variants. I imagine that there was some variability between patients who were carrying and those who were not carrying a variant. So I wanted to understand a little bit, did you perform some matched analysis, or did you try to be sure that there was not any confounding factors that could impact the results?
Yes, we performed an exploratory retrospective matched pair analysis, and we used the matched pair analysis to select patients which are comparable between the DPYD variant carriers and the DPYD wild-type patients to ensure that on the most important factors, they were comparable and outcome was also comparable. So in the matched pair analysis, we compared progression-free survival and overall survival between DPYD variant carriers treated with the reduced dose and DPYD wild-type patients treated with the full dose. We matched those patients on 5 matching variables, which were primary tumor type, stage of cancer, age within a bracket of plus minus 10 years, sex, and treatment regimen to ensure that these patients were as comparable as possible.
And so now moving on a little bit to the results, what were the results in brief regarding progression-free survival and overall survival for the patients who were harboring a variant in the DPYPD gene and those who were wild type for this gene?
The results of our study showed that there was no significant difference in progression-free survival and overall survival between the DPYD variant carriers pooled as one group, treated with the reduced dose, compared to wild-type patients treated with the full dose. This suggests that DPYD-guided dosing can be performed safely without compromising treatment effectiveness. However, when we take a closer look at the individual variants, we see that our study showed that progression-free survival and overall survival were not negatively impacted by the DPYD-guided dosing in the 2846 and the DPYD STAR 2A variant groups. However, in the group of the 1236 variant carriers, we did find a significant difference in progression-free survival with a hazard ratio of 1.43 indicating that progression-free survival was shorter compared to the matched wild-type patients treated with the full dose. However, no difference was found in overall survival. So based on the results of the study, I think we can conclude that DPYD-guided dosing can be used while treating patients with fluoropyrimidines without compromising effectiveness and improving safety. However, when patients do not experience toxicity or experience minimal toxicity, it is important to escalate the dose guided by the toxicity to ensure a maximum exposure to the treatment.
Thank you very much. That was a very comprehensive overview of the results. I was really wondering regarding the variance in the 1236. So the one that you said was associated with a shorter progression-free survival. At the very beginning, Dr. Cats very well explained that in the first prospective trial that was done, among these patients, toxicity were still higher, or they experienced more severe toxicities, even with a 25% dose reduction compared to what was planned. So I was wondering if you could speculate a little bit. So do you think that this reduction in the progression-free survival might potentially be associated with these higher rates of severe adverse events, and that maybe this has created a little bit of gap in the adherence to chemotherapy?
We looked into the mean dose that the 1236 variant carriers received, and this was about 75% of the dosage. So the dosage was what the protocol prescribed for the study. And also the number of cycles did not differ from the wild-type patients. So I think the patients did not stop earlier with their treatment than was intended to. What we did see, however, is that in the whole group, only 10% of the variant carriers did have some kind of dose modification, which could be both an increasement of the dose or a reduction of the dose. So there were only a few patients where the dose was modified. We know that the 1236 variant carriers, it is a very heterogeneous group. DPD enzyme activity also shows a wide range, ranging from normal to a very low dose. And even we described a patient with a homozygous 1236 mutation. And we would expect that there would not be DPYD enzyme activity, and there still was DPD enzyme activity in this patient.
That's a very good insight on this particular topic. So just related to the conversation that we are just having, do you think that in general, for all DPD variants, and in particular, as we discussed for the 1236, do you think that genotyping is sufficient for now to understand which is the right dose for these patients to balance toxicities and to obtain the best clinical outcomes? Or do you think that we need like more sophisticated or more integrated types of monitoring? For example, should we, for example, in the 1236, look more carefully at pharmacokinetics and so understand if these patients can receive higher doses? Because maybe, as you were saying, the activity of the enzyme is really higher than what we are expecting based on the genotype. Do you envision something like this happening in the future, or do you consider it as a potential line of research in this topic?
It's a very interesting question, and it's something we've thought about a lot. So at the moment, I think genotyping is the way to go and is the most robust and most validated method currently available with fluoropyrimidines. And I think it's a bit of both. So currently, as mentioned, I would recommend DPYD genotyping, and also in the 1236 variant carriers, as we have seen in previous studies that toxicity is still increased even while administering 75% dose instead of a full dose. So we see there's still more toxicity. However, also our study also shows that progression-free survival is shorter compared to wild-type patients. So it's quite a complex situation, as we still have more toxicity. However, the progression-free survival is also shorter. And that's where we would advise the dose escalation part. So I think it's a combination of genotyping and escalating the dose when possible if there's no toxicity or limited toxicity to ensure the maximum exposure and to minimize the effects on the progression-free survival and still try to reduce toxicity.
This is a very important question because we do not understand completely why toxicity is higher in the 1236 with a 25% dose reduction, but may compromise progression-free survival. So we have to look in closer detail. And currently we are looking in closer detail to what do we have for pharmacokinetic analysis, like you mentioned. What about DPD activity, enzyme activity? Can you titrate on that? And I think for now, it still stands that we should start with a 50% dose, but with the possible effectiveness of the dosage in mind, you should go with an early titration. And I would say something about 25%, although having said that, I have no data to underline this. And if you have the possibility to go for DPD enzyme activity in addition to genotyping, that would also help you to titrate dosage on that. And that's where we stand now. But we need to know why this 1236 variant carrier has such a large range in activity and toxicity.
I also think, and I can ask you if you agree with me, that this analysis is really very important because I think it's one of the first reports regarding the analysis specifically of progression-free survival and overall survival based on variants of DPD. But at the same time, I think that we also have to underline for our listeners that this was still a retrospective and exploratory analysis. So it's true that you observed this association with shorter progression-free survival, but still I think that we will need also more cohort studies to validate these findings and to be really sure and also to perform additional analysis as to what is the mechanism, as you were saying. I don't know if you agree on this limitation of the study, despite its importance in regarding clinical outcomes.
We certainly agree with you that we have to keep in mind that it is an exploratory retrospective analysis. Having said that, a randomized controlled trial certainly has some difficulties in it as well. Nowadays, it is not feasible to give patients with a DPYD variant a full dose. In 2018, there was a lawsuit in Oregon, and now recently in Ontario, Canada. There's also a lot of rumor in the news because of patients getting full dose while having a DPYD variant. So the lethality of the toxicity in some variant carriers makes it not ethical to perform a randomized controlled trial. So we have to look for different designs that are reflecting real world data and learning more about the genotype, and also in different ethnicities. It is also very important because what we have studied considers the white population mostly. And that's also a direction that future research should go to.
Thank you very much. That was very insightful, especially the last part regarding ethnicity and the possibility that also these variants might be different according to that. So I think that the main message that we should pass is that when prescribing fluoropyrimidine's, genotyping of DPD is fundamental because toxicities among patients harboring these variants can be severe, can also be lethal. You performed this retrospective exploratory analysis that provided us with overall reassuring data. There is some research more to be done, especially for the 1236 variants. So I think that that probably is our bottom line and main message for our listeners. And I just had one final question, because in the manuscript that you published, you had localized, locally advanced, and also metastatic cancer that were all grouped together. Do you think that an additional line of research would be to specifically look at how these impact on outcomes only in the locally advanced and localized cancer compared, for example, with the metastatic?
You raise a very good point, because there is a lot of variety within this study. And now you're mentioning locally advanced, local or metastatic cancer. It's also within the cancer types. We studied different cancer types as well, just to reach a large amount of patients. It would be good to have a more homogeneous population that you can derive your conclusions from. So yeah, I think that would certainly help us in the future, and we should look whether we could do this together, because before we have such a large population, we need several countries to work together.
Yeah, you're totally right. Thank you very much for underlining that last point. Thank you very much, Dr. Knikman and Dr. Cats, for being here with us today and for explaining to us and to our listeners the results of your research. That concludes these episodes of JCO Article Insights. We discussed the manuscript titled Survival of Patients with Cancer with DPD Variant Alleles and Dose Individualized Fluoropyrimidine Therapy, a Matched Pair Analysis. This is Davide Soldato, your host. Thank you for your attention and stay tuned for the next episode.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.